why don't we do some introductions? Claire, why don't you go first?
Hiya. Hi Adam, thanks for inviting me on. I'm Claire Surr and I'm Professor of Dementia Studies at Leeds Beckett University and Director of the Centre for Dementia Research there.
Thanks, Claire. And Victoria?
Yeah, hi. So I'm Vicky Shepherd. I'm a Senior Research Fellow at the Centre for Trials Research at Cardiff University.
And both of you do work not only in care homes, but part of your work is looking at care homes as well, which is going to be what we're going to talk about partly today. Victoria, why don't I stick with you? Why don't you tell everybody all about your work?
Sure. So I'm based in the clinical trials unit. So we, of course, design and conduct clinical trials and lots of other types of studies, some of which are in care homes. So I'm involved in those. But then a lot of the focus of my work is thinking about how we can conduct research that includes groups who are traditionally not included in research. So that includes people living in care homes, people with cognitive impairment more generally, including people living with dementia, particularly where there might be issues around their ability to give consent to take part in research. And of course, that involves a lot of ethical, legal, as well as the kind of more practical or methodological challenges that might be encountered. So that's the kind of increasing focus of my work at the moment. And that includes things like conducting qualitative research with researchers to find out what the kind of things that help and things that challenge them when we think about conducting research with people who might not be able to give their own consent, as well as developing specific tools. So part of my work has explored how family members make decisions about research on behalf of people who are not able to give their own consent. So that's sort of consultees and legal representatives. And I've developed a tool to help them through that kind of process of decision making. As well as some of the work I do is to develop tools to help researchers to design more inclusive research. So we've just finished developing the NIHR INCLUDE Impaired Capacity to Consent framework, which is particularly for trials, but not exclusively, to help researchers design a trial to be inclusive of people who have challenges around consent. And we held a launch webinar a couple of days ago, and we've produced a kind of whole toolkit of resources to help researchers, as well as doing increasing focus of my work, as well as thinking about how we can encourage people to undertake advanced research planning. So we used to think about advanced care planning, but we're not used to thinking so much about how people can be encouraged to talk and perhaps express their wishes about research should they lose capacity in the future. So maybe aligning it with things like advanced care planning or power of attorney arrangements might help people then who are unable to give their own consent. Their kind of family members would know what their wishes and preferences are if they're no longer able to express them themselves.
I think your work's really made a big difference, hasn't it, to being able to navigate that space? Because I mean, when I started working at UCL 12 years ago, when we first started to look, and Claire, I think you were around at the time as well, you were at Bradford then, but looking at, there was so much sensitivity and unknown about how you practically research people living in care homes, and the consent thing was such a big issue for a long time. I don't know if it's less of an issue now because we know more and there's more of that research going on now, but it was so, people just didn't know where to go. Where do you go to get consent? Is that the local authority? Who does it? How do we take it from people? Is this the care home? Does the care home need to give permission? Do individuals? Is it family members? How does it work? Do you feel that you know, from your research, is that clearer now, or is this still something that needs to be looked at more?
So there is some more clarity, I think, and that's partly through people who've kind of been through that process. So researchers like Claire kind of talking about what the kind of process they've been through. So we learned more about how people have done it already, if you like. And then my work, as I say, explore some of that in a little bit more detail. But I think there are still challenges. So if we think that perhaps 70 to 80% of people living in a care home won't be able to give their own consent to take part in research. So any study being conducted in care homes really has to include people who lack capacity to consent. But researchers are still quite worried about it. The qualitative study I mentioned, one of the quotes from a care home researcher was talking about how this whole issue is like a black box of horrendousness, that they were terrified to go anywhere near. They were worried that the kind of ethics police would come for them. So there's still a lot of kind of fear and uncertainty around researchers, which leads them to exclude people. And then issues around research ethics committees and how that kind of process of approval works. Again, people often find quite difficult.
And I'm sure I won't be embarrassing by saying, I think you've both been at and Claire particularly, like breaking new ground with this, because there wasn't a lot of care home research going on in care homes. Care home residents were underrepresented in research a decade ago, and it feels like there's a lot that's followed since. And certainly, Claire, I mean, you've felt like you've been at the cutting edge of that for 10 years now. Is that my age? My age?
Yeah, it's probably even longer. I mean, my
is.
PhD was in care homes back in sort of 1998. I started that. So I've been doing care homes research pretty much my whole career, and things have changed massively. And we've got a lot more guidance, but I do think it is still a challenge. But I think one of the principles I've always worked from the basis of is being able to take part in a research should be a right for everyone, and that there's a very sort of protectionist perspective that we've got to protect people from researchers who might do terrible things to them. But actually, on the other hand, taking part in research can offer so many benefits to people. People want to take part. Sometimes it might be an interview study where they get a really nice chat with a researcher, and I think so. We always kind of try and argue the case of, often ethics panels do ask you, could you do this study with people who don't lack capacity, with people who don't lack capacity, and you have to kind of always argue the case. Well, no, we need people who don't have capacity to take part, because that's the care home population, and if you exclude them, A, the research isn't relevant to everybody, and B, why should they be excluded from taking part just because they lack capacity? It should be everybody's right, and we've got processes we can follow. So I think the Mental Capacity Act has helped immensely, though, in terms of really being clear about the guidelines people need to follow.
Yeah, and the support you can get. And I completely agree. I mean, as one of the people who takes credit for bringing about joint dementia research, which we've talked about a lot today, one of the main purposes of that was to remove that kind of middleman from research, because that kind of middleman, but that kind of midway step, that these gatekeepers of research were the clinicians, that you couldn't get involved in a study unless the consultant invited you to, or unless this particular person found you and offered you. And having that way of putting your hand up and saying, hey, I want to do things, was such an important part of that. And I think we found during the pandemic particularly as well, when those clinics weren't running in quite the same way anymore, it's how we managed to keep research going is through that direct volunteering process, which is a bit different in care homes, because that's where NIHR comes in, which I'll get a plug in for, nrihr.nihr.ac.uk, which is a UK care home network run by the NIHR, to allow care homes to come forward and participate in research, which isn't just about the individual residents, but also about care homes as organisations, which I think brings us on to your work, Claire. Tell us about your research.
Yeah, so as I've mentioned, I've done quite a lot of care homes research, and that's where I really started out as a researcher, initially looking at research around what does good care look like in care homes, and my PhD study about sense of self and how people living with dementia in care homes manage to maintain or struggle to maintain a sense of self. But then moving on from there, my work's really been around looking at interventions and approaches that staff can apply to improve care practices, so tools like dementia care mapping and other approaches like that. I'm involved in another study at the moment led by the University of Lincoln, looking at a cognitive DAISY assessment tool for staff to look at different areas of people's cognitive abilities and disabilities, and how people's care can be planned on that basis, so that you're working with people's strengths. So there's that kind of intervention research in care homes. I've done a lot of research around education and training for the dementia care workforce, so quite a bit of that in care homes, but also the sort of hospital and health and community-based staff, looking at what makes good education and training, what are the sort of, what's the content like, how is it delivered, and then we've got a programme of work particularly looking at cancer and dementia and other comorbidities. So we've done work in outpatient oncology services, but we've got a portfolio of work looking at that in care homes, acute oncology services, and we've got a project starting in the new year looking at how cancer is managed in people with dementia in primary care and in the community.
Because that's been a controversial topic recently, Emily, because isn't there been this kind of resistance where some health services might have said before, oh, we're not going to treat the other condition because you have Alzheimer's, and so you won't benefit from treatment for this, but the attitudes to that changing?
I think so, and it wasn't, I don't think we came across in our study in oncology services, we didn't come across anyone who said, actually, we just do a blanket thing. If somebody's got dementia, they're not going to be treated. We actually found people, cancer services seem to work in quite a person-centered way. They work in a very individualized way, despite the sort of pressures, and they've got, targets they have to meet. We found people really quite willing and wanting to work in individualized ways. So they would make very individual assessments based on how a lot of it's down to frailty. Yeah, a lot of it's frailty. But then also some of them were kind of thinking of that bigger picture. So have they got somebody to support them if they're having chemotherapy, and the symptoms and side effects? What will they manage with? Surgical options obviously mean your body might look different afterwards, and how will somebody cope if they're not actually going to remember that they've got that diagnosis? So there are a whole lot of complex issues there, but we found people working in cancer services, despite a lack of dementia education and training, often they were really trying to grapple with those in quite complex ways. I mean, there's a lot to be done, but I think we found people have been really open to the research and really wanting to work in different ways.
That's great, and I mean that's exactly what you want to hear, isn't it? So yeah. I'm going to bring you back. I mean, well done. I think so much of your work has made a big difference to care homes, and some of the people watching today will be carers or people living with dementia, or they'll have family members living in a nursing home. From what you've learned over this long period of time that you've worked in this space, what does a good care home look like? What would you look for if you were looking for a care home or somewhere where your family member could live? Victoria, go on, you go first. Sorry, I caught you on mute.
That's fine. So there's lots of ways that you could find out what kind of care a care home provides. They undergo regular inspections, and those are all publicly available. But nothing replaces, I don't think, going and visiting a care home and actually experiencing what the care is like and what it's like to receive care in a care home. And you get a sense as to how well the staff know the individual residents and families, how welcoming a space that they are, as well as actually seeing, the facilities they provide, the services they provide, what the kind of ratio of care staff is, and how well trained they are. Of course, COVID has made that very difficult, with care homes obviously being closed to visitors a lot of the time. But I think a lot of it is around going and experiencing what that kind of care looks like and feels like, as well as speaking to people that have already experienced care in their care home. But a lot of it is the people that work there and the kind of culture and ethos that's present in the care home, and how well trained the staff are, which obviously links back to Claire's work. But yeah, it's about that kind of caring attitude and how that might be evidenced, I think.
So making sure that that you look at the people as much as you do the bricks and mortar. It's not just kind of, have they got nice rooms that are painted the right colour or lack of. What about you, Claire? Is there anything you'd add to that?
Yeah, I think it can be easy to be drawn in by a very glamorous brand new building with lots of swish carpets that looks a bit like the very nice hotel you'd like to go to for a weekend. And I'm not saying homes like that can't be wonderful places, but I think it is about understanding the people that are in that space. So a stable manager is really important, and the manager really drives everything else. So being able to talk to a manager, speak to them about, how the care home works and being made to feel welcome, I think are really important. And then
that's a good question then, like asking how long has the manager been there? How many have they had over the last couple of years, maybe?
Yeah.
They change that often.
They can change often. And I mean, maybe the home there has been a change of manager and the new manager might be great, but I think it's getting a real feel for that person, because who they are then tends to reflect in the culture that works within the care home. And I think it's about thinking about what's right for the individual with dementia and their family and supporters around them, because a care home that might be right for one person might not be right for another person. So it's really about fit as well, and thinking, can that care home provide what that particular person with dementia needs and the family.
And there's that compromise as well, isn't there? You've got the cost and the geography, and are they close enough to where you live, and have they got space? I mean, I know it's a complex decision. Do you come across how care homes, how do people deal with that kind of carer guilt of quite often? Is that dealt with as well by that advanced kind of planning that you were talking about before, agreeing in advance? Because I've talked to so many people who feel, and you see them on Twitter and things as well, who feel guilty when they put when they support their loved ones to go live in a care home.
Yeah, they can be incredibly complex decisions, and one that I think really benefits from thinking and talking ahead of time. So if someone is living with dementia and is requiring more care, having an early conversation around what someone's wishes and needs would be is really important, I think, and being wary of making promises that you might not be able to keep, I think. So, if you're caring for someone in their own home or in your home, you will want probably to do that as long as possible, but someone's needs may be to the point where they're complex and you're not able to provide that support in the home, and they do require more help and support. And for people that have kind of feel like they've made a promise that won't ever happen, but circumstances mean that is really the only alternative place of care, it can be very difficult. So I think having honest and open and supported decisions ahead of time really helps.
And that advanced planning, again, it kind of helps avoid that, doesn't it? Because so many people resort to care homes after some kind of, is this still the case that care homes often come into play after there's been some kind of big incident? Somebody lives on their own, they have a fall, and somebody eventually says, hey, that person can't go live on their own anymore. And so those decisions are all too often rushed and not ideal. And that's when we see people's cognition decline as well, isn't it, after these incidents? So planning ahead is important. If anybody's watching who works in a care home, what advice would you give to them on how they might improve their knowledge or training? Because I know lots of people who work in care homes aren't nurses. They might have been supported to do some qualification, but what more specialist stuff would you recommend or advise them? Where would they go to get more dementia specific help?
I go on this one. Yeah. I mean, this is the kind of thing that a good care home should be providing. So they should be providing access to training and development and learning opportunities, and directing staff to where they can find those. I mean, there's a lot of good stuff available. For example, Sky have got a lot of good training and information on their website. So SCIE. I
was just going to say, yeah.
SCIE.org.uk. So the Social Care Institute for Excellence. So they have a lot of really good resources on their website. There's obviously lots of videos and podcasts. I think my advice would be wary about where you go to, and go to one of these reputable websites, because if you just look on YouTube or somewhere like that, there can be all sorts of stuff on there that might not be the best advice.
Training scammer companies and things like that are not great.
Yeah. So I think it really depends what knowledge and information you want. So there are lots of websites linked to projects that will have, I saw people on the end of the last session, so there were people talking about their research outputs and dissemination. So I think it's about finding ways to find reliable sources of information. And if you're not sure, link in with, if there is a local university to you or one of the people you've seen on the Chatathon. We really don't mind it if we get an email from somebody who says, I think you do work in this area, I want to know more. Have you got any resources we might use in our care home? We might not get back to you the same day, but we'll definitely, most researchers will try and guide people to useful resources. So
I'll try and dig out some links and put those in the website as well. And I know I think I mentioned earlier on today as well, NIHR evidence is quite useful for certain things. They've done lots of different reviews to summarize some of the evidence in different areas, and quite often reading up on those. I don't know if you're going for an interview in a care home and it's new to you, that, you know, knowing what the latest advice is on continence or falls or good care or planning and consent, all these things will be quite useful to you, I would imagine. The pandemic, of course, we haven't talked about the pandemic a great deal today, but it's hard to not talk about care homes and at least think a little bit about the pandemic. This has been a very serious half an hour. What have we learned from the pandemic about care homes, and have those lessons? I have this kind of concern about whether we've really learned lessons. If we have a bad winter, are we just going to repeat the same issue? Are all care homes just suddenly going to close down again like they did before, or not close down, or not? Have we learned from the mistakes, do you think? I don't know, Victoria.
So we've learned some, I think. But I think what COVID also highlighted is that if we concentrate on doing research in areas like the NHS, like in the community, and don't think about research in care homes, we don't know the evidence. And I think that's part of the picture in care homes, is that we didn't really have a good sense as to what was effective in terms of keeping residents well and healthy. And that means everything about their well-being, not just avoiding catching COVID and becoming ill from COVID in care homes. And that's why some of the work that we did in COVID in care homes was looking at what kind of outcomes you would look at when doing COVID trials that don't focus just on how many residents get COVID and become ill and die from COVID, but also the implications of having some of those infection control measures that meant that the care homes were closed to visitors, and the harm that then does to care home residents who rely on that social contact. And because the trials that people were doing were just focusing on illness from COVID and not capturing what really matters to people living in care homes, working in care homes, and caring for people who live in care homes. And I think unless we really recognise that doing research in care homes is the only way that we will learn lessons, we do risk repeating that again. So hopefully that's one of the messages.
Yeah, and I think it's a difficult balance as well. We did some work looking at visiting policies and practice. We're just hopefully about to submit that for publication. But one of the things that we found from that was getting that balance right. It's really difficult. We did surveys with care home staff and managers and family members of people with dementia who were living in care homes during the pandemic, and we asked them about questions about how would you balance different things like keeping the person safe from getting COVID versus having more open visiting, and which one of those would they prioritise. And it was pretty much 50-50 down the middle for all of the answers. So what you do that would be the best thing for one family and for one resident might be the complete opposite of what another family or resident would want. And I think also there were the other problem, and I don't know that we've learnt from this, was the guidance and then leaving it really to care homes to make their own way with that. So the guidance was not very guidance, kind of, and I think people were left to find their own way through the pandemic, and that's why we got such massive differences in what was happening. So you might have one care home here, and just down the road you've got another care home where the visiting policy was completely different, even though they were in the same street as each other. And I think that was really difficult. The same
kind of policies from the
government. It was really difficult for people, I think, to understand that, and it was so difficult for care home managers and staff because they were left to make these really difficult decisions about, do you keep people safe and try and keep COVID out the care home, or do you focus on well-being and what's best for people and allow the visiting? And sometimes it was an impossible decision, I think, when they didn't, as Vicky said, didn't have any research and any evidence to be working from.
And whilst I think it's still in living memory, so I think the knowledge about, when to wear masks, how to wear gloves, how to use hand hygiene, how to use distance and space and decontaminate places and things like this is still there. As you say, the chances are that you still got two care homes down the road from each other. They might have a new updated policy which I'm sure they would present nicely to potential new residents. So this is what we'll do next time, but they could still be different with different approaches, and quite whether one will be more successful than the other is still a little bit remains to be seen. But it's great to see that so much of the research around COVID and care homes is now very rapidly making its way into that space. But I don't know if you would agree, I think we still have this challenge, particularly in care homes, is that translation, is taking what you get and putting it into the hands of those people. And journals with firewalls or not even having access to journal articles because you have to be a university affiliation to access journals. Otherwise they charge you thousands of pounds per year to read that. It's just rubbish. We totally need to get better in that system. And I think you in your work and programs like Ideal have been great in slightly citing that, saying we'll publish the results, but that's different from sharing the findings, and treating those two things as separate, I think, is so important.
Yeah, and some of the work done here in Social Care Wales, where they have curated research pages, so they actually bring together research intended for people working in social care, so care homes and domiciliary care, can really help put it into the kind of language that people will be able to take up and understand. So there are certainly ways of doing it.
Thank you very much, Professor Claire Surr and Dr. Victoria Shefford, for your brilliant time. That was so thoughtful and interesting over the last half an hour. Thank you so much for joining me.
You're welcome.
We're going to be moving on now as my next guests are dropping into the... Joe suddenly got surprised. He wasn't expecting to be on camera when he came in. Thank you, Claire. Oh, and they've gone. And we've got our next group here. Joe suddenly got surprised. He wasn't expecting. And we've got a big group this time as well. Look, this is a big one. This is a 4-person one. I should have given you more time. Somebody's not going to get talked. Hands up that if somebody's going to talk least, who wants to be that person who talks the least? I mean, Megan, don't use the excuse of returning from maternity leave as being.
Hey, I'm not even back yet.
You're not.
And I'm poorly, but no, I'm happy to.
Okay, then if I've got awkward questions, I will try and dodge.
I'm really happy either way.
To you. Okay, so let's pop a caption up on the screen. There we go. So coming up over the next half an hour from 6 p.m. This is such a shift. It's quite hard to shift pace from talking about care homes and difficulties during the pandemic to talking about pathology research. Learning from brain tissue and the brain bank, which is what we're going to be talking about over the next half hour. The reason why I should explain, the reason why the schedule is so eclectic, because I did ask all the researchers, like, when are you free during the day? And then tried to group people together. Everybody said, oh yeah, I want to do the morning. So everybody is in the evening has been very kind. But this is where you'll find there's lots of 2-person groups over the next 3 hours. So pathology research, learning from brain tissue and the brain bank. And over the next half an hour, I'm going to be joined by the people who you can see on the screen. We've got Dr. Lauren Walker, who's joining us as an ARUK fellow, joining us from Newcastle University in the North East. We have Dr. Megan Torvill, who's a research associate at the UK Dementia Research Institute in Cardiff. Oh, sorry, you're not actually Welsh though, are you?
No, just the name.
So we don't have to worry about talking about football.
And then, I'm Welsh.
I didn't do well in Wales, but I don't know.
Okay, we'll stay away from football then. Do you know what? I suddenly realised, oh crap, the World Cup's on, and it wasn't until Wednesday I thought I better just check what games are on. It'd be just my luck we did this, and there was an important game. I don't think there's anything massively important on tonight.
Depends who's listening. Right. Some people might be from countries where they think, yes, it's very important.
They might be. We also have Dr. Keely Brooks-Baker, who now has a hyphen to your surname from when you were last here. So congratulations. I assume you've got married since the last time you were here. And we have Joe Morgan. Sorry, I should add, your senior lecturer from Nottingham Trent University. I'm sure was senior lecturer there last time as well. You were postdoc before. Is this a promotion?
Yeah. Yes.
Congratulations. And then we have Joe Morgan, who's a PhD student at the University of Salford. This is where I usually play a film. So I'm going to do that. I'm going to play a film very super quickly. I'm going to pick one of the short ones, and then we'll be back in 30 seconds time.
When I was racing, Helen was always by my side. We've been married for over 60 years. In 2015, Helen was diagnosed with dementia. It's a cruel disease with no cure, but I want to change that. Let's beat dementia together.